Hello and welcome to today's webinar titled Prevent Meets Primary Endpoint, a detailed look at the practice-changing results and real-world experience with breast cancer-related lymphedema prevention. March is Lymphedema Awareness Month, and we want to recognize the patients, caregivers, and advocates working to improve the lives of millions of lymphedema patients worldwide. Today, you will hear from 4 physicians who have been instrumental to this journey and innovators in preventing chronic lymphedema in cancer patients. Dr. Pat Whitworth, breast surgeon and director of Nashville Breast Center, who will moderate today's session. Dr. Dr Dupree, breast surgeon in Sedona, Arizona. Dr. Manpreet Kohli, breast surgeon and director of breast surgery at Monmouth Medical Center. And Dr. Chirag Shah, radiation oncologist and co-director of the Comprehensive Breast Program, director of breast cancer radiation oncology, and Director of Clinical Research at the Department of Radiology, Cleveland Clinic. This webinar will include didactic presentations followed by panel discussions. You may participate by submitting questions or comments via the Q&A icon on your screen at any time. Now I would like to invite our panelists to come on video and introduce Dr. Pat Whitworth.
Thank you, Joanne. First, I will go ahead and introduce our faculty members. We have some what we consider to be very exciting news and, in fact, practice-changing news. And so we're really pleased to have an opportunity to share that with you. Our panel, we'll start with Beth Dupree, who is well known to all the members of the American Society of Breast Surgeons. She's been teaching us for many years the importance of the mind-body connection and mindfulness and how patients can find healing, not only through what we do, but through what they learn to do for themselves. Beth is channeling all good things from Sedona, Arizona, which is a great place to channel things from because there's a lot going on there that you can't quite see. So Beth, welcome and thank you for being here.
Thank you, Pat.
We have Dr. Preeti Kohli, who is Director of Breast Surgery at Monmouth Medical Center. She is on faculty in the Rutgers system, and she is here to tell us about her journey, quite a journey, implementing this practice-changing technology in her institution. And everybody knows changing your workflow, changing practice is not easy, and it's not something that we take lightly. And so when something comes along that really is compelling, it's worth talking about how did you actually pull this off. So we're thrilled to have Dr. Kohli with us. And then Dr. Chirag Shah, who was one of the leaders of this prospective randomized practice-changing trial. And Dr. Shah is very modest, but this is quite an accomplishment to be involved in such a practice-changing event. And we're thrilled to have him here to sort of explain what happened in the trial and what the results show and what they mean. I think we can go ahead and start with some comments from Dr. Dupree, just giving us a little more background and a little more information, sort of focusing our minds on this problem that we all deal with, breast cancer-related lymphedema. Thank you, Beth.
Thank you, Pat. And I am humbled and honored to be part of this amazing group of physicians and very excited to be talking about breast cancer, lymphedema risk, and early detection tonight, as it's where it all begins. So next slide. Clearly, just look at the numbers. When you look at the number of women and men being diagnosed with breast cancer annually in the United States, we're upwards of 290,000 now. And unfortunately, 82% of them are at risk for developing lymphedema, which means 1 in 5 patients will potentially develop lymphedema. And we need to be able to identify which 1 in 5 patient it is, but you can't do that by randomly selecting patients to test for lymphedema or to follow. We need to come up with a program to be able to follow all of our patients that are at risk, and that would be 82% of them. Next. It's unfortunate when you go into your office hours and you see a patient on the far right of the screen in stage 2 or 3 lymphedema, because we know at that point we have potentially missed the boat to be able to help that patient. Stage 0 and stage 1 lymphedema are oftentimes not able to be perceived on physical exam. Therefore, we need to utilize other resources. When I started out in my clinical practice 35 years ago, we used to tape measure. We did the best we could that we had at the time. But back then we were also doing axillary node dissections. We hadn't even heard of sentinel node biopsy for breast cancer care. And this is one of those practice changing times that we all kind of need to get on the bus and move forward in the world of preventive care. Next. So breast cancer lymphedema comes from multiple factors, and this is unfortunate because these factors are additive. And when you look at a sentinel node biopsy, which would potentially progress to an axillary node dissection, someone that needed a mastectomy with radiation therapy, taxane-based chemotherapies, and obesity. Obesity is one of the risk factors that we really need to discuss with our patients at the time of diagnosis. It's not something that you want to tell someone that, I like to say that they need to grow a little bit taller or lose weight. Either option works for me, but we know that elevated BMI is a risk factor for a lot of things with cancer, but particularly lymphedema. And 60% of breast cancer patients do get exposed to radiation therapy. And although it's something that we need to prevent the recurrence of cancer, it can actually increase the risk of lymphedema. Next. This is a evaluation of patients reporting arm lymphedema based on prevalence at 2 years and 15 years. And you can see that with surgery and radiation therapy combined, at 2 years is close to 25%, at 15 years it'll be close to 45%. So these are additive things, and the risk doesn't go away. And we know that finding lymphedema before it is clinically apparent is really our only hope at being able to prevent progression of disease. Next. I was an early adopter, loved the technology SOZO. It was in all our clinics and physical therapy offices out here in Sedona. Happy to say it's in my clinic back in the East Coast now as well. Bioimpedance spectroscopy measures extracellular fluid, and it's fast, it's painless. It literally, for me, it became a vital sign in my office practice. And we monitored the patients every 3 months for 3 years, and then every 6 months for another 2 years. And it was, we did it as one of our NAPBC quality metrics to be able to follow these patients as part of our NAPBC accreditation. Next. This is what a normal scan looks like. You like to be in the green, green is good. And what we're doing is we're following a cumulative course of the patient from pre-operative assessment to post-op to their follow-up clinical visits. Next. The guidelines are supported by everyone, the American Society of Breast Surgeons, Oncology Nursing Society, National Lymphedema Network, you name it, and it's out there. The Learn Lymphatic Education Research Network. Everyone understands that lymphedema, once it gets to the point that it's clinically apparent, we've missed the boat. We've missed that opportunity to intervene. Next. One of the most important things is we need to follow the NCCN guidelines in order to be accredited centers of excellence, which requires education of the patient, persistent monitoring on a regular basis, making sure the patient gets a referral for lymphedema management, and early detection is the key to this process. We also need to know that as we're going forward, I think the guidelines are going to get more specific in what's required, because now that we have data to support these early, the trial, the PREVENT trial, they're going to have to follow suit and make sure that our patients are all getting pre-treatment measurements. Next. So lymphedema education, it follows 3 areas: exercise, prevention, and lifestyle education. All of our patients go for preoperative assessment. They're given a focused H&P. They're given exercises that they can do safely after surgery by our physical therapists. They're also given education on risk factors, signs and symptoms, and they're set up for their SOZO exam every 3 months for the next 36 months. We also talk to them about strength training, range of motion, balance, exercise, and the very important factor of a healthy BMI. And we know that SOZO can not only help monitor for lymphedema, but also for skeletal muscle mass and body composition. Next. So I found that patients find this measurement very, very interesting because they recognize that obesity also puts them at a risk for elevated circulating estrogen. So a lot of my patients really like to have these other measurements to be able to follow how they're going post-operatively. Next. So 35 years ago, there was a lot of misinformation out there. Patients were told to not use their upper extremity, which led to about 33 to 58% of patients having arm and shoulder issues of either frozen shoulder or decreased mobility. And overusing the upper extremity immediately right after surgery is not good, but that translation into not using it at all was incorrect. Next. Proud to say that out of the University of Pennsylvania, the physical activity lymphedema trial looked at survivors with and without lymphedema. They were placed in twice-a-week progressive strength training with a non-exercising control. And this was a 1-year randomized control trial. Next. And the outcome to me was something that was absolutely practice changing, particularly for breast cancer patients. There was a 50% reduction in the likelihood of lymphedema worsening with strength training in the lymphedema group, and a 70% reduction in the likelihood of lymphedema onset in women who had 5 or more nodes removed. It also helped increase strength and energy, improve body image, reducing body fat, and prevented a decline in physical function. So getting patients involved in exercise programs after surgery, I think, is incredibly important to help prevent lymphedema. Next. So early detection is the key. And with prevention, what we're talking about with prevention is identifying those patients at risk before we can physically see a change in the physical appearance of their arm. Next. This is actually a graph of one of my patients, and I will tell you, I wasn't very happy between the beginning and end of March of 2020. We were already stressed out enough. It was during COVID. I had done her surgery in early January, and by the time COVID hit, she was well into her radiation therapy, and that was her first measurement, was during radiation therapy at the beginning of March. Thought we had made some progress. A couple days later at physical therapy, and we actually were testing her almost every 2 to 3 days. She was getting compression wrapping and lymph star treatment. And happy to say that as we got through the worst of COVID, we also got through the worst of her risk of lymphedema at that point and got her back down below her baseline. And to me, this is a win. This is a patient that, had I not known that she had increased more than 6.5 points in her LDEX, I might have missed the opportunity to reverse her lymphedema before we ever had a chance to do so. So this is this was one of those ones that if you ever have a question with your administrators about whether you need to bring this technology in, this is the kind of patient that we really did change her life. Next. We know that clinical lymphedema, when it gets to stage 2 and stage 3, 0% are expected to resolve. So we have to find these patients at the subclinical stage 0 or slight stage 1, where we have upwards of 88 to 100% chance of resolving the lymphedema. And we only do that by making our SOZO part of our vital signs. Next. First 3 years is absolutely the highest risk, but that risk doesn't end. But the reason why we choose to follow our patients every 3 months for the first 2 years and then every 6 months for another 2 years is because we want to get those patients, because 75% of them will show up with their lymphedema if they're going to develop it within the first 3 years. Next. And it's unfortunate, but the more we do to patients, the bigger the intervention, the higher the risk. So we go from a sentinel node biopsy alone at 6.3% risk up to a 41% risk with chest wall, superclav, and posterior axillary boost radiation therapy. And I'm not saying this to throw radiation oncologists under the bus. That's not what this is about. We treat patients based on the stage and extent of their disease. We have to treat them aggressively based on their clinical and their pathologic staging. But what I can tell you is we have an opportunity in those patients that are at super high risk to be able to potentially catch them and change their treatment course. Next. So it goes from either early treatment, which can be at-home treatment, or chronic lymphedema, stage 2 and 3, which requires pneumatic pumps, potential hospitalization for infections. Next. You're going to hear this again because this is one of the important take-homes for you. Test, trigger, and treat. If you don't test, you're not going to find it early. You won't have the trigger of an increase of 6.5 or more to get into treatment. And the treatment can usually be done at home if we catch it early enough. Next. And there is a cost to delaying the identification of lymphedema. The cost related to cost unrelated to cancer treatment increases the longer we wait to identify lymphedema. Next. This is not the picture that we want to see with our patients. Nightly bandaging, 15 minutes a night, 365 days a year. Next. 1 hour of CPD self-care takes up 14.8 days of their year, every year. So that's 2.5 weeks that they're not on vacation. And that's an hour, that's in a 24-hour day. So 14.8 days per year. So it's not something to laugh at. This absolutely negatively impacts your patient's outcome. Next. So finding it subclinical versus early versus late changes the difference in treatment from the cost and the amount of time, 2 weeks per year versus 4 weeks per year versus 6+ weeks per year when you get up to 3 hours a day for treatment. Next. So it's not so much about the $2,000 that's going to break the bank, but if it's a recurring burden, that extra $2,000 is also can cripple patients over that recurring burden can cripple those patients over a long period of time if they have to continue to pay out of pocket. Next. My favorite saying, you've got to be the change you wish to see in the world. And yes, that is a view from my porch. I thank you for your attention. If you take away anything from this evening, you have to change how you think about lymphedema not being preventable, because when you find it early, we can change the course of a patient's life. Thank you.
Beth, thank you very much. I shared with Beth the other day the saying, the affirmation I like to have on my slides. It says, be the person your dog thinks you are, which is a real aspiration for me anyway. Beth, that really was a nice summary of the challenge that we have and what we're up against. Beth and I were early adopters of this technology, and we ran into a lot of challenges because we became convinced early on, just from our clinical practice, and this is always dangerous for surgeons because we're sort of anecdotal creatures. We became convinced that this was really important for our patients to find lymphedema when it was subclinical. And so we were evangelistic about it. We told a lot of people about it. We recommended it. And what people found out was that they really could not sustain it because it was not covered by insurance. And no matter how many studies were reported, insurance said, you know, we're waiting. Insurance companies said, we're waiting for a prospective randomized trial. And that's why I'm just so grateful to Dr. Chirag Shah as one of the leaders of this prospective randomized trial, that number one is going to lead to, I think, full coverage by everyone. It's already led to reversal of most denials, about 98% of the denials that have been appealed. So I'm very pleased to introduce Dr. Shah to go into a little bit of detail about this study and why it is a real practice-changing event. Dr. Shah.
Thank you so much, Pat. And it's my pleasure to discuss the PREVENT trial on behalf of my co-investigators. So the trial was entitled A Comparison of Bioimpedance Spectroscopy or Tape Measure, Triggered Compression Intervention in Chronic Breast Cancer Lymphedema Prevention. Next slide, please. So I know for many of those on this webinar, some of this will be kind of well-known information, but we know that our outcomes with breast cancer are improving. And with that, we're seeing a greater number of patients really transition into long-term follow-up and survivorship. And it's in those moments that we really need to think about long-term patient quality of life and the side effects of the therapies that we deliver. Lymphedema rates, as Dr. Dupree had mentioned, range pretty widely, from anywhere as low as 5%, someone who has an excision alone, all the way up to 50% in some patients who have, trimodality therapy, including, advanced radiation therapy to the lymph nodes. And this breast cancer-related lymphedema can translate into pain, infection, as well as high costs, as Dr. Dupree noted, and can really impact a patient's ability to work and care for themselves and their family. And really the impetus behind the PREVENT trial was previous studies that had suggested that early detection of subclinical lymphedema in those early stages that we'd previously seen, combined with immediate short-term compression therapy, not lifelong, but short-term compression therapy, can prevent chronic cancer-related lymphedema. Next slide, please. So the primary aim of the PREVENT trial was to really determine if subclinical detection of extracellular fluid accumulation via bioimpedance and subsequent early intervention reduced the rates of complex decongestive physiotherapy relative rates seen using standard volume tape measurements coupled with early intervention. Next slide, please. This is a typical report. I know Dr. Dupree went through a couple of her reports, and this is one that was kind of similar, one that went up and then, with intervention went down again. And really, it's a point of care assessment. It measures up to 256 frequencies at 1,000 kilohertz and can detect changes as small as 2.4 tablespoons. Importantly, it's been validated against lymphoscintigraphy. Initially, the studies using bioimpedance used an LDEX score of 10. However, during the trial, we've adjusted this to 6.5, which has high sensitivity and specificity in detecting subclinical lymphedema. Next slide, please. So I want to talk a little bit about the tape measurement arm of this study, because this wasn't your average tape measurement arm. This was a gold standard tape measurement arm. We really tried to stack the deck against bioimpedance by really coming up with a gold standard tape measure. So this is a study technique that's been used in NSABP trials as well as other trials to assess for lymphedema. And so we wanted to use that as the quote unquote standard for this arm in terms of standardization. And this tape measure protocol included measurements taken every 10 centimeters with a minimum of 5 measurements per arm. Measuring board, seen in this image here, was used. Standardized tape measure was used to ensure consistent tension. Each arm was measured twice. And then each site in the trial was actually trained annually to make sure we were in consistency of measurement. So I'm not sure you're going to see this level of tape measure in most clinics, but we wanted to compare against the best tape measurement we could do. Next slide, please. These are the inclusion and exclusion criteria of the trial. We started with patients who had histologically confirmed breast cancer, whether that be invasive cancer or DCIS, planned for surgery. Post-surgically, they had to have stage 1 to 3 breast cancer or stage 0 DCIS with at least one of the following features: mastectomy, axillary therapy, radiation therapy to the chest and breast, axilla, and or supraclavicular fossa, or taxane-based chemotherapy. Exclusion criteria included a previous history prior to diagnosis of breast cancer, planned bilateral surgery, previous radiation of the breast, chest, axilla, previous lymphedema therapy, medical known conditions that are known to cause swelling, an active implanted medical device such as a pacemaker, or allergies to the electrode adhesives or compression fabrics. The adhesives is no longer an issue given that the new device doesn't require these adhesives. Next slide, please. This is our trial design. So we started off with a pre-treatment baseline assessment using both LDEX and tape measurement at the time preoperatively. We subsequently randomized patients post-operatively if they met one of those criteria. They were randomized to the LDEX arm or the tape measure arm. The tape measure was 5 to 10% because over 10% was felt to be clinical lymphedema. So we didn't want to include those patients when subclinical. And the LDEX was initially 10, but we went back and adjusted it at 6.5 and accounted for that in all the patients who have been assessed. In terms of intervention, we used basically anyone with less than a 10% change after a trigger. They were given a compression sleeve and gauntlet for 4 weeks, 12 hours a day. Anyone over 10% was automatically sent for CDP, as this was felt to be not subclinical, but clinical lymphedema. Following using the compression garment, patients were then followed. For consistency between the arms, we went back to using everyone with tape measurement. As long as you stay below 10%, we followed you for up to 3 years. And if you were over 10%, we sent you for CDP. And we were followed consistently. Similar to Dr. Dupree's recommendations, we followed every 3 months with optional visits at 15 and 21 months. Next slide, please. This is just the consort diagram showing we start off about 1,200 patients. We enrolled 1,200 pre-surgery and included 963. We randomized 481 to tape measure and 482 to bioimpedance, with 437 and 442 available. Similarly, between the arms, there was a good balance between those patients that progressed pre-intervention as well as those that had no post-baseline assessment. So a well-balanced study. Next slide, please. These are the baseline characteristics: similar age, similar BMI. If you look at the stage, similar rates of DCIS and stage 3. If you look at the groups of stage 1 and 2, maybe slight differences between them, but when you look at them together, stage 1 and 2, which have similar treatment paradigms, really no difference. Next slide, please. These are the rest of the treatment characteristics. If you look at surgery, really no difference between breast conservation, mastectomy rates, chemotherapy rates, radiation, endocrine therapy, or even pooled risk categories. There's a slight difference in dissection rates, but if you look at that rate of about 3% difference between the arms, when we review the results, you'll see that doesn't come close to looking at the difference actually between the two treatment arms. Next slide, please. In terms of the intervention for those that were triggering, whether that be in the tape measure or in the bioimpedance arm, they were given a sleeve and gauntlet that was 23 to 32 millimeters of mercury. They were asked to wear it for 4 weeks for 12 hours per day. Next slide, please. In terms of the results, I'll start at the bottom and work my way up. So, the primary outcome was progression to CDP. And what you see here is a 11% more, greater than 11% difference between the rates of CDP between tape measure and bioimpedance with LDEX. So clearly a clinical benefit of more than 10%, but most importantly, also a statistical benefit. In terms of the triggers, I'm often asked why there were more triggers in the tape measure. And then when you look at the numbers, it actually starts to make sense. So at first you may say, why is tape measure triggering so much earlier than bioimpedance? Well, it's because you're getting a lot of these false positives with the tape measure. But if you actually look at the total time of a patient, whether they be in the tape measure, the LDEX arm, from any form of triggering to actually progressing, they're almost identical. It's about 14.6 in the tape measure arm, and it's actually 14.6 in the LDEX arm. So LDEX is not only detecting the right patients, but it's allowing you to then intervene and change the long-term result of CDP. Whereas tape measure, you're triggering early, but you're triggering in the wrong patients early. You have that increased rate of triggers, the false positives, and it's not actually translating into improved long-term rates of CDP. Next slide, please. And honestly, this is one of the most beautiful figures I've seen because as a clinical trialist, you can't get better than this, right? When you look at the subgroups of your trial, you always hope that they're all going to be consistent. You never expect to see a straight line for a forest plot. And so what this really shows is however you slice the populations up in this study, whether you look at BMI, mastectomy, dissection, radiation, chemotherapy, the benefit with LDEX was consistent across the board. If you look at those odds ratios, they're almost identical across the board. Next slide, please. In conclusion, these results really show that bioimpedance spectroscopy screening with early intervention reduced the rates of chronic lymphedema using complex decongestive physiotherapy as a surrogate, and is really the standard of care for prospective BCRL surveillance. Bioimpedance was more specific for lymphedema detection than tape measure, as it had fewer triggers and longer times to intervention. And bioimpedance compared to tape measure really provided precise identification of patients likely to benefit from early compression therapy. Next slide, please. These are some of the PREVENT publications. So obviously I highlighted the final analysis. We've also had some data on why we switched from 6.5 to 10, our interim data, our trajectory data, as well as data looking at how this can be incorporated into any kind of breast cancer practice. And then also we've done cost studies showing that this is actually a cost-effective approach to prospective surveillance. Next slide, please. Finally, I'd like to thank all the patients who enrolled in this study and really made the trial possible, as well as all of my colleagues and co-investigators at all these wonderful centers who participate in the trial. Thank you very much. Oh, I apologize. Actually, I was gonna add a couple extra discussions. So this is separate from the PREVENT study, but there was a large meta-analysis performed in breast cancer research and treatment. So this was a study that we led that actually included 50 studies looking at lymphedema in almost 70,000 women. And this was really modeled after a previous lymphedema meta-analysis performed that was in the Lancet. And the idea was to look at rates of lymphedema comparing bioimpedance, circumference, and background. And if you take these data together, we looked at first the annualized rate, and it was about 4.9% with background, 7.7% with circumference, and 1.5% with bioimpedance. So if you show that to any patient, that's kind of a no-brainer. And then if you look at the cumulative rates, about 13% with background, 17% with circumference, and 3.1% with bioimpedance. So a 69% reduction with bioimpedance as compared to background, 81% as compared to circumference. And if you look at these data, it doesn't really matter how you slice the pie again, whether it's patients with less follow-up, only 2 years or less, or greater than 2 years, you see the same benefits with bioimpedance compared to circumference or background. If you look at by the type of study, you're seeing the same type of benefits, and these were all statistically significant. Next slide, please. We also looked at subgroups, saying what if they had a high rate of axillary dissection or a low rate of axillary dissection? Still seeing really substantial benefits with BIS as compared to circumference. And then if you look at mastectomy rates, obviously mastectomy may not always be correlated, it may be a surrogate for other advanced factors, but still you're seeing consistent benefits with bioimpedance. Next slide, please. And then this was the economics analysis based on the interim PREVENT trial. And really one of the questions I get asked is, well, tape measure is cheap and easy, why wouldn't I do that? Well, we actually decided to look at kind of based on the interim analysis. When you factor in the cost of the SOZO units, the staff requirements for that, the cost of sleeves and triggers, cost of CDP, what actually turns out. And we use the trigger model from the interim analysis as well as the progression model. Next slide, please. And we accounted for patient costs, staff costs, everything in there. And what we found is that really the cost of staff did not drastically alter the cost per visit for the patient, due to short time required. It takes less than 5 minutes to make an LDEX measurement. Next slide, please. And what you can see here is regardless of the size of your practice in terms of breast patients coming through per year, the cost per visit and per patient with bioimpedance spectroscopy is actually quite low. Next slide, please. And when you actually do a comparison of bioimpedance to tape measure, not only is it low, but it's substantially less than that seen with tape measure when you actually account for the cost of measurements, the cost of staff, sleeves, and CDP. Next slide, please. So overall, the costs were lower with LDEX surveillance as compared to tape measure when accounting for measurements, compression, sleeves, and CDP. And this is really seen irrespective of patient volume. And when incorporating hospitalization costs, it went even further in terms of the cost savings with LDEX. Next slide, please. So in terms of conclusions from these studies, breast cancer-related lymphedema is associated with reduced quality of life and increased healthcare costs. A prospective surveillance model of care and intervention can really improve outcomes and reduce the costs of care. And evidence supports LDEX as a standard approach for BCRL surveillance. Next slide, please. Thank you very much.
Chirag, thank you for that additional information. The question came up in my mind because looking at the tape measure technique that was used in the study, which was, clearly, I've never seen that before, where they put a strain gauge on the tape measure to make sure they're just putting the right amount of tension and they're measuring 5 spots. Did we get any data or were there any estimates in the study about how long that takes to do that sort of state-of-the-art tape measure approach?
Yeah, so, we don't have all the data for that, but I can tell you that it's substantially longer than a SOZO measurement. So not even counting the fidelity training for that or all the extra, work that goes involved, but it's substantial. I mean, that is not, having to measure twice, having to measure 5 points in the arm, bringing the board out. Anyone who's used the SOZO now can tell you that that's, you can measure 5 patients in the time of doing one of those, Pat.
My goodness. And, the thing that we did all along, as Dr. Dupree pointed out, was try to follow the guidelines, try to monitor patients, try to see if they develop. It was part of every survivorship program. It was a quality metric. But all we could do with tape measure was detect maybe stage 2 before it went to stage 3. And that's good, maybe preventing progression from stage 2 to stage 3, because that's awful to have that big swollen arm that ultimately the fluid gets replaced with fat. But we really weren't in a position to find things with tape measure at that subclinical stage with much more effort now. We still can only do that. And I've never seen anybody using a strain gauge and a tape measure. And I've known some very, very dedicated physical therapists, occupational therapists in the past. So to me, that really stands out. If we have practice changing data, thank God it's not tape measure, because incorporating that into everybody's workflow for every visit, I don't think that's going to ultimately be practical. A couple of other questions come up when you look at this data set. People wonder, in the first place, some people wonder, is it true? How can you believe it? It's just like any other prospective randomized trial. It challenges people's assumptions, but then that's why it's the gold standard. That's why we can change practice. That's why insurance is going to start covering it. But up until now, and this was why we had pushback in the past, people would say, well, maybe those little upticks in extracellular fluid compartment volume, maybe those didn't mean anything. Maybe they were just going to reverse themselves on their own. And now we know from this data set that there's a dramatic difference in the number of people that trigger and go on. So that said, since this data has come out, Dr. Coley, have you had more success just talking to colleagues, talking to your administrators, or did you have to make this journey sort of halfway through the study?
I think that it certainly helped to have this study when talking to payers who initially wanted to deny it. So it's been extremely useful, other than just, before speaking passionately about patient care and why it's important and what impact lymphedema has on a patient's life. Having data to support it it's vital. It's huge.
Well, I think one of the true experts, and we just fortunately have him here with us today on the economic impact here, Dr. Shah has published and done a number of economic analyses. And I think it's even possible, and correct me if I'm wrong, Chirag, but I think it's even possible to reassure the health system at risk or the insurance company that the cost of lymphedema without early detection in a given population is higher than the cost of prevention. Is that true?
Yeah, I mean, I would say, Pat, I think I look at it from a couple ways. So first I start, from the patient perspective, and I think Dr. Dupree really highlighted that. That's a clear win. I think then when you look at it from the payer perspective, if you look at the data that we used in our analysis and the data from PREVENT, which we'll hopefully update with the final analysis as well, it's clearly a benefit from the payer position. And then if you look at it from the provider and the system position, more and more we're being asked to share risk when it comes to the management of patients in terms of being paid fixed rates for different things. And this is one where if you're in that type of model, it's also going to be a benefit. So I think regardless of how you look at it from an economic standpoint, bioimpedance is going to come out as a cost-effective choice in prospective BCRL surveillance.
Well, I'd hope that it's clear so far that it's sort of incumbent on practicing breast surgeons, folks who care about women with breast cancer and their quality of life and their management. If you don't have this capability in your practice, if women in your practice don't have access to this kind of early detection, many of them will really go on to develop lymphedema that could have been prevented. So because that journey is so difficult and can be so challenging today, I mean, I remember when we could tell the OR administrator, hey, I'd like to try this new technology. It's really promising. And they'd say, oh, well, you want it Monday or like next week? And now, of course, it's like getting an act through Congress to get a different kind of scalpel. So Dr. Coley has really gone through this journey and sort of written a guide for how at least you can go through it in one health system. So I'm very happy to have Dr. Coley here to tell us how she did this and maybe make some suggestions, and then we can try to talk about some of the particulars that are in challenges that are in different systems. Dr. Coley.
Perfect. Thanks, Dr. Whitworth. So yeah, I would definitely say that if you've made it this far, lymphedema is a problem. That SOZO is a really great way to identify it early. And now you may want to know how to do it, how to build a program. And I would love it if you could learn from my experience, because there was certainly some troubleshooting along the way that hopefully I can save others. So, you can go to the next slide. So, just to review, as our other panelists have mentioned, Dr. Dupree, Dr. Shah, early intervention is going to provide the best opportunity to reverse lymphedema. That's going to help reduce long-term complications associated with lymphedema that's chronic. It's going to overall improve the patient's quality of life. I think that how you broach the conversation, first of all, with patients is, I've heard in the past, doesn't that freak them out if you're going to talk to them about lymphedema? Isn't that something that they shouldn't even be talking about? They're probably overwhelmed with the information pertaining to a breast cancer diagnosis. And I think that you need to reframe it, because breast cancer survival rates are overall much better than they ever have been. And if you're able to tell the patient, I have the skill set to do what I need to do to treat you from an oncologic manner in the most thorough way, and we've considered all of these ways of de-escalating nodal management to avoid lymphedema. Sometimes that it will still, it's a potential in the future, and it's very reassuring to patients to know that you will do whatever you need to do to make sure they have a future that they're looking forward to. And we're thinking of that in part of our treatment plan. And I think that reinforces those survival rates. You can easily quote, this stage has a 99% survival rate. But if you're telling a patient, when I see you in 3 years, we're still going to be doing this test, because if there's any uptick that's above 6.5, I'm going to make sure that we're able to reverse that. And quality of life is huge. That's going to set you up for good survivorship for the patient. Next. So how do we do it? Who is tested? Who does the testing? What resources are needed? And what does an ideal workflow look like? These were questions that I had to answer and almost build prior to this PREVENT trial. So you can go on to the next slide. The evolution of my program, I think it's important to go into that background. So in 2017, a donor provided the LDEX U400. So that was the predecessor to SOZO, where there were leads, and it is bioimpedance spectroscopy, and it is our way of detecting lymphedema. It was used at that time to confirm a diagnosis of lymphedema. So patients that were coming in with a swollen arm, I was using this as a tool to confirm that diagnosis and then prompt further intervention. So we gradually started moving towards trying to detect it earlier, okay, not waiting for lymphedema. So we kind of cherry-picked patients and said, let's test the highest risk patients, the ones that have had an axillary lymph node dissection. And what we found over time, that became very burdensome for the office staff, because they were searching through the months, schedule of patients to determine who had a node dissection, how many nodes were removed. The other aspect of it was, it was provided by a donor. We were doing it free of charge, and the electrodes for that unit were getting costly. The system I work in was starting to pay attention. And as a background, I am a community-based physician, but I'm part of one of the largest healthcare systems in New Jersey. So there are certainly, layers to this. We pushed to change to the SOZO, which addressed the cost of the leads. So we were able to test without having that issue, and test at unlimited. So we weren't wondering, do we have to reuse a lead? And then, there was actually this push by the system. Let's dig ourselves a little bit out of this hole. How can we get, there is a CPT code with this. Why don't we charge the patients? So the patients getting tested were actually finding that their insurances weren't covering it. At that time, this was still considered experimental, and they were getting balance billed, sometimes upwards of $400. Gradually, newer data led to coverage expansion, but you could see how troubling that would be, that you're trying to test the highest risk patients, and those are the ones that really didn't want to have to pay that amount. It's quite a lot. So, Medicare started covering this. The system agreed 400 is a lot. We'll match Medicare's rate if it's not covered. We'll have the patient sign this advanced beneficiary notice if it's not covered. And unfortunately, the damage had been done. They either had a very recent memory of a very high bill, even $150 seemed like too much, and they were opting out of SOZO, even though we came to that agreement in the system. Next slide. So we were not testing the highest risk patients, and also there were patients that may not have been on our radar, ones that we might not have thought to be at such an elevated risk, who were missing an opportunity for intervention. So what did we change? In September 2021, not that long ago, we changed quite a few things. We started testing all at-risk patients, and I learned that you need to just cast a bigger net. You need to test everybody. This is truly going to be, and it is the vital sign of breast care. We moved this unit to the intake area where vital signs are taken, and each patient gets it. There's no more searching for who had what. It is a cancer code in the system that's very easy to find. And testing all the high-risk patients, testing everybody took the burden off the staff, and we started working with ImpediMed's case assistance program. This was almost life-changing because we grant them access to our electronic medical record. They have view access, and they're able to access all the information they need, which is provided for claims. So we have all the patients tested, we get pre-approvals. They know if this is approved by the time they get to the office. If it's not covered, it is then sent on to the case assistance program. So by testing a wider population of patients, even if several claims may not be covered, we're definitely covering the cost of having SOZO, building this lymphedema prevention program, and hopefully attaining some profitability too. Next. So this is just another, bird's eye view of how things evolved. We started with the SOZO unit in 2019. Almost all the patients were new. The dark ones are new because it was a new unit. And over time, the pandemic in 2020 caused a dip in cases. Then when we made the change to billing patients and having them sign a waiver, our compliance dropped steeply. The only patients that were getting tested were ones who either had all the highest risk factors, where I almost insisted they have it, axillary node dissection, radiation, chemo, ones that were having it covered, or ones that were uber wealthy and didn't mind paying out of pocket for it. I was very upset to see the program I was working hard to build failing, and that's when we started some discussions about how can we change things, and all of those changes that I implemented were instituted in September, and you can see the drastic difference over the past 6 months. All the new patients are getting tested. You can see January when the follow-ups were all telehealth, only those new patients were being tested. That was during the Omicron spike here. But it's a drastic difference. And, again, even if they're not all covered, you're making more than you would certainly if you were testing 2 patients a month. Next. So translating this into practice. So this is one of my medical assistants who's doing the study, and this is going to show you exactly how easy it is. It's easy for the staff to perform the measurement. It's easy for the patient to be measured, and it's easy for the physician to interpret. So those barriers are not really barriers, that she's wiping down the unit so that there's moisture for the patient to step on the unit. She simply puts her hands in the cradle, and then the nurse or medical assistant enters in what height, weight, and it is calculated in a matter of seconds. Of note, this video is pre-pandemic, which explains the lack of masks. This patient was symptomatic with lymphedema. This was prior to us moving it to that vital station, and there was no baseline for reference. She agreed to have this video taken. She wanted to show, how bad her lymphedema was. Her measurement initially was 28. It was very much out of range. And she had symptoms, you could see that she was losing those bony prominences in the wrist. Her veins were not as visible. She had some bogginess of the upper arm, and her jewelry was certainly tighter, and of course, this is what we want to avoid, but this is just a good overview of, doing the test. It's very quick. So next, so to make it successful, you have to have a very defined protocol of how it's going to be done and who's doing what. So I don't like to take on big projects myself as a physician, and I think that's an important thing. Physicians want to know what's in it for me, and how much is my office staff going to hate me. And it's very simple. My nurse does the test. I approve that order. She documents the results. Because the case assistance program has view access to my notes only, I copy that result into my note. She enters the CPT billing code when she's documenting her SOZO measurement with the vital signs. I approve that when it drops into my inbox. So far I've only copied a note, approved an order, and then she gives me the printout, or she shows me on the computer what the measurement is. That's when, you did the test. Now this is the trigger. What's the difference? And do we need to treat? So at my institution, we refer patients to physical therapy. They do the measurements for compression garments. They do lymphedema exercises. They do lymphatic massage. Next, and then afterwards, make sure that your intervention has reached its desired outcome. This is the same patient. You can see how much better her arm just looks visually. And this is her SOZO, where, she didn't have a baseline, but she's way, way better than she was. And she really just wore a sleeve and did some massage therapy. Next. So the code is 93702. Okay, you can enter it, your medical assistant can enter it. So whether you're private or you're an employed physician like myself, this is important. There's reimbursement and RVUs associated with it. You're going to use any of these codes, and this is a text that we use that gets dropped into the EMR. The only things that need to be changed are, is it a baseline? Is it a follow-up? Is it within normal limits? Or what is the measurement? I prefer to have the actual measurements in there so I don't have to look for anything. Next. So with the appropriate documentation, the case assistance program is able to help, and it has made a dramatic difference in my practice. So the case assistance program through ImpediMed, they handle all the processes required for reimbursement. They help facilitate patient access to testing. It is a HIPAA compliant system, and they are available for anyone who obtains a SOZO unit for their practice. So you can see that I have had nearly 350 cases go through the case assistance program. 163 have been approved, 183 are still active, but only one has been denied. So there's a 99% success rate as of yet. Next. So what are the challenges that I face? The main three: convincing your system or your practice that this is worthwhile and that it might be profitable. Securing and reimbursement coverage to help prove that, but also for the sake of the patient. You don't want another financial burden for a patient. And how to create a workflow that aligns with best practices and is not going to burden the staff. So, with the organization, we had an organizational goal as part of our quality improvement initiatives, as Dr. Dupree mentioned. This is something you can use for your NAPBC accreditation. This was to elevate the care of our cancer center in a cost-effective way. And it also gives us a competitive edge. No one else in our area has this as of yet. And it really sets us apart, defines us as a program. So with the case assistance program, we're securing that reimbursement for those who we can, because we're working with them. The workflow is much smoother. It's not burdensome for the staff. We don't need special staff just for this. And we are certainly making back what the investment was. And the patients are not worried about this being something that they have to walk around with. Some have actually gone to collections in the past And that is something that I would feel very, very bad about doing to a patient. And the workflow. So streamline it, test all the patients. That's going to, even though it's a bigger population, it's much easier to do that. Streamline the ordering process. The documentation has been made for you. You just have to, do minor adjustments. And that makes it quite easy. It almost sounds so easy after the fact that I can't believe I went through all that initial stuff. Next. So why is it worth the effort? Because the outcomes that I've seen so far. So you are providing the best level of care for your patients. You're setting them up for successful survivorship. They are thinking of their future and not getting so overwhelmed in the moment. Your system and your practice is certainly making back their investment. You are decreasing the cost of those, healthcare related, the spending with chronic lymphedema. And in my case, we have in-network physical therapists. And so we're not only saving down the road, but they love that I'm sharing the wealth within the system. If there's somebody that needs further intervention, they're going to physical therapy. So I get points for that. And the most important thing is you're just elevating the care of your cancer program. You're doing your best, you're pushing forward to provide the highest level of care. And you're keeping up with current data that proves this is worthwhile. Next. So, what do we do? Best patient care and reimbursement coverages. These are the best practices. Test everyone. I know this is repetitive, but this is important. Test everyone. Make it a vital sign. It is more vital to me than somebody's blood pressure, because I will refer them back to their primary or their cardiologist if their blood pressure is out of range. But this is a direct result of an intervention that I did. And I want to be able to, find it, trigger, and treat. Streamline your process. Don't make it burdensome for your staff. And to do that, really lean on the case assistance program if you need to. They're very helpful. And make sure you have, a next step. If somebody is triggered, what are you going to do next? And that's how you really complete the whole package of creating a functioning and successful lymphedema prevention program. Next. And that's it. I just wanted to thank you. And this is some of my team, and that really little cute one with dark curly hair is my daughter. So, all right. Thank you so much for having me. And I'm happy to answer any questions.
It's always nice to end with some cuteness. That was really nice, Preeti. One of the things that we ran into, and I'm setting you up for this, but I'm guessing that you probably are doing the same thing. When we talk about who to test, we tied ourselves in knots when we first started doing this, just like you did, looking for who had this many lymph nodes removed, or who was overweight, or who had this combination of treatments, a sentinel node and breast radiation, whatever it was. And it was very burdensome to all of us, the staff in particular, because that's who we tried to get to do it. And we realized it takes minutes. It takes less than 5 minutes, certainly. And well, you demonstrated that. And what we realized is we can do it on everybody with a diagnosis of cancer. And that's easy enough to figure out. Anybody who's had a diagnosis of cancer. And then when it gets to the doctor who's seeing the patient for her follow-up visit, if that doctor says, oh, this patient wasn't really at risk, they don't charge for it, because that's the person that approves the charges or puts in the charges as the physician. So if you see somebody who had, DCIS and a lumpectomy and nothing else, and you think, well, this patient's not really at risk, you don't charge for it, but you don't have your staff doing backflips in the EHR trying to figure out who needs it or not. We just do it like we weigh patients. Is that what you do?
Me, yeah, we do it for everyone. And if it's not approved, we, have them try again and try. Eventually, if it's denied, we will adjust it. The system has agreed to just drop the charge.
So I did see a question. Some folks were wondering, is this case assistance program something your hospital set up or something the company set up?
So this is actually through ImpediMed. They have their, reimbursement case assistance program, and it is not through the hospital, but there was a contract signed with the hospital, an agreement that they would be allowed access to the EMR and, provide services to help streamline the process.
Well, I can tell you that I thought I was capturing all of my patients. And a couple of friends of mine who also use this technology said, we bet you're not, because I had a physical therapist in the office. I thought, oh, we're scheduling her, they're seeing them. And so when we went to that method of putting it in the check-in station, we tripled the number of patients we were capturing and testing. So I'm convinced that's true. Dr. Shaw, is that what you do in your clinic?
Yeah, we do a pretty similar thing. So our SOZO is in our multidisciplinary breast clinic, and it sits right next to our weigh scale, similar to Dr. Coley. And it's actually quite nice. The MAs, when they get the rest of the vital signs, they get the SOZO on all the breast cancer patients, and then it's uploaded to the cloud. So it's actually very easy for us to do. We do it in our MDC, which makes it very easy.
You know, we get a lot of discussion when we talk with experts in lymphedema. And it's sort of it's a little bit of a how many angels can fit on the head of a pin argument. But many of the experts that we've worked with will say things like lymphedema is permanent. It's not curable. It never goes away. Once you have it, you have it. And I tend to think, well, maybe there's a way in which that's true, but I'd like to look at it from the patient point of view and to say, you know, if you don't have a swollen arm that's bothering you, that's causing you a problem every day, maybe it's more that you're at risk and you maybe have had it before, you've triggered before, but you certainly haven't had that stretching of the extracellular compartment that won't reverse. Do you have people in your system that argue with you that say, well, they've got it, and so, you know, preventing it, it's just going to happen?
I think that, you know, anytime you initiate anything new, that's always a concern. But I think when people see the end results, it makes believers out of people. I think as clinicians, end of the day, we follow data, whether that be our own data or the large data. And I think across the board, we've seen in every discipline, people kind of come together such that we've expanded our program over the years and added more and more units to our different sites because people see the utility, and also patients are empowered to ask for it. So I think it's a two-way street. One, as clinicians, we're doing that, but on our side, patients are now more driven to say, what can I do to mitigate my own risks? So if you're not offering it, they're still going to be asking you for it.
I know that you're on a lot of the leadership committees that influence guidelines. In particular, I know that people will be more inclined to adopt this in their practice, feel it's more incumbent on them, maybe not because of a prospective randomized trial, but because it gets an official sanction like that. Can you update us at all on what the process or the progress might be in having this show up in the guidelines after the next meeting?
Sure. So I guess I don't sit on, you know, for example, the NCCN guideline committee, but I'll paraphrase one of your quotes, Pat, which is guidelines are the floor, not the ceiling. And I like that. And I think that really resonates here. So the guidelines, you know, are one, slow adopting. So, you know, we talked about doing partial breast 10 plus years ago, only now the guidelines will get to that. So I would imagine over time, the guidelines will incorporate these things. Guidelines are moving towards talking about early detection and early treatment, which was not something we saw even 5 or 10 years ago. So I expect the guidelines to come around, but at the same token, it's not really the ceiling. If you're trying to deliver world-class, highest level care, I'm not trying to follow a guideline. I'm trying to really define the practice the guidelines going to follow. More the opposite way.
And you know, it's interesting in this particular case, the physical therapists are leading everyone, and that the physical therapy organization, American Physical Therapy Association, I think has maybe 10 times more members than most of our professional associations, and they officially in their guidelines recommend bioimpedance as a way to screen for lymphedema, and they also recommend if you have an increase of more than 6.5 that you should be seen by a physical therapist, or at least provided with preventative intervention. Dr. Coley, do your physical therapists, once you've referred the patient over, you've detected this in your office and you've referred the patient over to them, do they also use LDEX to monitor the progress the patient's having, or do they send them back to you?
They don't. They looked into it for a little bit, but our physical therapist is located immediately adjacent to my office. So it felt a bit redundant when they could just stop into my office and get a measurement. So it's in a pretty centrally located area for us to use, even if, you know, they're just coming in for a measurement and not an actual visit.
I've had that question come up, and you and I are both very fortunate in that way, and I know Dr. Shah is as well. But I think most breast surgeons may not have such easy access to a physical therapist. And I've asked some physical therapy centers about this, and they are telling me it's something they want, and it's a logistical challenge. But I think most of them are hoping to partner with a physician who will be able to write the order for it, because they can't just write orders themselves. It's a little bit like, you know, mammograms. They need an order from diagnostic mammograms. They need an order from someone.
How does it work for your practice, Dr. Dupree? Because you have it in the physical therapist locations?
So I was very lucky, because this is one of those things I always tell young surgeons when they're going out to get a job. When you get there, you need to ask for what you want, exactly what you want. Don't mince words. We were able to get a SOZO in my office, and also it's kind of a larger area here in Northern Arizona. 3 separate physical therapy locations have them, because for patient ease of access, we would have patients that would come down from the reservation and from the Navajo Nation. And if they have to drive to my office to get a SOZO, that would have been an extra hour and a half. So for patient convenience, that was done, and it increased the compliance. It also, the physical therapists also use the SOZO for more than just the lymphedema. They also use it for the biometrics. But it made it very easy for the patients to hit the 3 and 6 month follow-ups, because if I was seeing the patients on a 6-month basis, then the physical therapist could see them at the other juncture. And we found that it was something that the patients actually looked forward to, because they like to see that they're doing well. And anytime anybody had a tick, we referred them directly over to PT, and then they stayed at PT until their numbers came back to normal with intervention. But I think that's the wave of the future. It's going to have to be bilocated in physical therapy and in the breast surgeon's office, because those are the 2 points of entry where the patients really need to have the scores done. And it was not an issue for us to give an order for the physical therapist to do a SOZO, because there are patients. It was pretty easy. And because everyone's in the same EMR, all the measurements go onto the same document. So it's not like one machine had one document, another machine had another document. It all went into the same, it was one patient within the same system.
We just had a question about patient compliance, both from a financial point of view, if they trigger, both from a financial point of view and from just a pure compliance point of view. What has been the experience of the group with patients when you say, well, you've triggered, you've got this elevated fluid accumulation, you really need to wear a compression sleeve 12 hours a day for a month. That's what we do for this. Have you had patients that said, I can't afford it, or who said, well, okay, I bought it, but I didn't wear it? Are we having challenges like that?
I didn't have challenges with patients that required treatment, because our physical therapist did such a phenomenal job at the pre-surgical education piece, where, like Preeti was saying, that there were some people, they don't want to talk about lymphedema, but even removing 1 or 2 sentinel lymph nodes can put you at a 6% risk. So there's nobody not at risk. I've had patients with DCIS with a lumpectomy and radiation therapy end up with lymphedema, and I didn't even invade their axilla. So all of those patients got followed, and the patients were actually quite grateful that they could have the intervention, knowing that 1 month of being inconvenienced with the treatment to be able to go back to normal and then just be followed. And that all comes down to patient education, because knowledge is power. And if someone doesn't understand that intervention can completely flip the switch and get them back just to regular, risk aversion with exercise and with continued follow-up, it's pure education for patients, to let them know that they're not, we're working to prevent them from progressing.
Dr. Coley, have you had any patient issues with compliance? Have you seen that?
I haven't. It's a similar experience. They feel grateful that it was found. They're happy that there's a solution and that it's not a never-ending thing. If you can kind of give a ballpark of 4 weeks, and we'd expect improvement if you're wearing a sleeve for 12 hours a day. they're usually really happy to hear that. And they love the thought that I can detect it before they can, so before they have, their jewelry feeling a little bit tight, that, we may find it, and that's exciting for them.
Well, I'm very grateful to everybody on our panel here. I'd like to give everybody an opportunity to finish with any closing remarks. I know Dr. Dupree will have some, so I'm going to start with Dr. Coley and then go to.
There's actually a question. There was a
Oh, you have a
question.
question?
There was a question that popped up. Garments are not usually reimbursed. How do patients that are told they need to pay for a garment, wear it for 2 weeks, 12 hours a day, respond to this?
Oh yeah, that was the one about compliance. But there is another one now. I don't know if you see this one. Does LDEX catch lymphedema, breast lymphedema, or is it just the limb? And that's a great question, because we do see breast lymphedema. I have not. LDEX does not catch breast lymphedema as far as I know. Certainly they can be associated, but breast lymphedema is generally almost obvious, although you always have to rule out infection. What do you think?
I think it's obvious when it's there clinically, and I've actually, my couple patients that had significant breast lymphedema also had changes in their LDEX and their upper extremity, which may be true and completely related to one another, because the edema of the breast, which is, it's secondary to the radiotherapy, can also be exacerbated by the lymphatic disruption. So, but early treatment, again, using, there's a lot of techniques that my therapist used for the lymphatic massage in the breast, have been able to significantly reduce it. I have some awesome slides, which we could do on our follow-up lymphedema, breast lymphedema. I didn't put them in this one though.
Well, and while this technology doesn't measure breast lymphedema, I think they do sometimes go hand in hand. Again, thanks to everyone. Dr. Coley, any parting remarks?
No, I just really hope that no one else has to go through the headache that I did in the past. And I hope that made it really streamlined and easy for anyone. So feel free to reach out to me if you have any specific questions about how I handle things. I have emails that I've had with like the VP of oncology and then the medical group director, and there's many layers of it to navigate. So I understand the challenges, but it's worth sticking with it.
Very good. Dr. Shah.
Sorry about that. I would just say at the end of the day, as you heard, this is a case of, patients first, data-driven, value-oriented. And I think at the end of the day, what you're going to see is kind of what we talked about. The guidelines will eventually turn that way. But to Dr. Coley's point, you're seeing payers cover it. You're seeing patients ask for it. So I think it's a win all the way.
Dr. Dupree, closing remarks.
So Pat, when we first started doing this, and I called it back when I was doing EKG LDEXs on my patients, we did it because we thought it was the right thing for patient care. And this all comes to survivorship. How we do what we do as surgeons, we can cut cancer out, but we can't cut out fear. And there are some complications in breast cancer care that we can't prevent, but this is a complication in breast cancer care that we now have the ability to identify early, to intervene, and to be able to treat it and reverse it before it becomes a long-term complication. And I just saw my lymphedema specialist, Sherry, is on here, and my lymphatic specialist, Sherry and Tiana and John, these guys, and Allie, they went to bat with the health system for me, because they knew what it's like long-term to see patients with incapacitating lymphedema, and they became my patients' champions. And for that, I am eternally grateful, because I believe that we've made a great difference in a lot of patients' lives and kept a lot of women from having daily reminders of their breast cancer diagnosis.
Well, for the folks who have stayed with us throughout this webinar, I think there's your call to action. And again, thank you to everybody on our panel. And I think we'll let the team wrap it up. Thank you.
Thank you.